Hello, students. Thank you for joining me today. This will be our second installment in basic pharmaceuticals. So this is part 2 of 3. If you haven't seen part 1, go ahead and watch that before you continue on with part 2. So we'll pick up right where we left off. So concentration and effect. So dose response curve. So pretty much what this is saying is if you take a little bit of drug, you're going to have about that much effect. If you take a little bit more drug, you'll have a little bit more effect. And if you take a lot of drug, you'll have a lot of effect. Right? But at a certain point, there's diminishing return, and no matter how much you take or have, you're not going to get more response. However, this doesn't take into account human variability. So, for example, with alcohol, if you drink alcohol regularly, your liver is going to make the enzymes for it, right? Alcohol dehydrogenase and acetylaldehyde dehydrogenase. So they'll make those enzymes. If you don't drink alcohol, then your liver doesn't need to make it, right? A better way to relate is using the blood concentration time profile. So this is an example of BAC. Not how many drinks you've taken, but if you ever renewed your license or your registration, they always give you a little BAC handout, blood alcohol concentration. So here in California, if you're 0.08%, then that is a DUI. 0.04, I think that's likely DUI. I'm not sure. So here is the curve. When you take the drug initially, there's none in your system, and then after a while, it absorbs into your blood, and then your body starts breaking it down. So during clinical trials, this is how they determine the frequency of dosing, whether it's every 6 hours or every 8, 12 hours. It's usually determined here. All right, let's take a look at the different parts of the curve. The first one is MEC, minimum effective concentration. So that is the time it takes for the drug to actually take effect. So let's continue on with that alcohol analogy. So if you take some alcohol, you usually don't feel it right away. It takes a little bit of time, 10, 15 minutes, right? So in this case, what concentration, blood concentration is needed to get an effect or a response? So in this case, you need to be at 2. So if you take the MEC and follow it over, blood concentration of 2. Onset of action. So how long will it take for the drug to work? So if I take it right here at time 0, it's not working. It doesn't start working until this point in the curve. And at that point, it's about 2 hours. Onset of action. Next, we have minimum toxic concentration. So this is when you start to have overdose effects. So the undesired effects. So in this case, on this curve, at a concentration of 4, you'll start seeing increased adverse effects. Therapeutic window. So therapeutic window is the range between MEC and MTC. And this is where we want to keep the patient. So we want the drug to work, but we don't want too much drug that it starts to harm the patient. So we got to keep them within that window. So for antibiotics, it's very important that you keep them within the therapeutic window. If the concentration is too low, the microbes will continue surviving and dividing. And for some antibiotics, if the concentration is too hard, you can damage kidney, livers, the liver, ears, etc. So in this case, what is the range? What is our therapeutic window's range? So from 2 to 4, we have a range of 2 units. Duration of action. So how long is the drug working for? How long is it above MEC? So here's our MEC line, and the drug is above from here to here. So from 2 to 10, so that would give us a duration of action of about 8 hours. So if this was in your clinical trials, part of your R&D, how often would you dose this medication? What would the frequency be? Q, what H? So changes in the blood concentration profile is probably a good indicator of what's also happening at the site of action. So for most drugs, not all drugs, you can make this correlation. The peaks. So we'll take the peak usually, I don't know, 1 to 2 hours after administration, depending on the route. And then the trough, we usually take that right before the next dose. So for certain antibiotics, you want to wait on making those IV bags until the trough information comes out, because most of the time the doctor will adjust the dose. Not all drug blood concentration time profiles reflect site of action concentration. So we mentioned alcohol, really straightforward, 0.08%, bam, DUI. But for THC, they were looking to use 5 micrograms, I think it was per deciliter, as their intoxication range. But alcohol works globally. It affects all parts of your body at the same time. THC, however, does not. So depending on if it's at the site of action or not, interacting with receptors, it may or may not impair the person. So we're looking, California just legalized marijuana. We're probably looking to see if there is going to be a test in the future. All right, let's review the concentration profile, blood concentration profile. MEC. MEC stands for minimum effective concentration. A, B, C, D, or E. If you chose B, you would be correct. Onset of action. How long it takes for the drug to start working after administration? Well, that's going to be D, the time MEC is reached. MTC, minimum toxic concentration. So that's overdose. The one that looks like overdose is A, increase the risk of undesired effects. The therapeutic window, we got to keep them above MEC but below MTC. So that is the range. And lastly, duration of action, the length of time the drug concentration is above MEC. ADME. So this is pharmacokinetics. Pharmacokinetics is what your body does to the drug. Pharmacodynamics is what the drug does to your body. So think of D for drugs, what the drugs do. In this case, we're thinking, we're doing pharmacokinetics, what your body does to the drug. So your body is going to absorb the drug. It's going to move it around. It's going to change the drug, and then it's going to have to get rid of it somehow. So on the blood concentration profile, they kind of overlap when things occur. So absorption would usually start immediately. And then once there's enough in the blood, distribution starts. And once the drug reaches the liver and kidneys, that's when metabolism and excretion will occur. And they put them together as one process. There's going to be 2 D terms and 2 E terms that you need to be careful with. The first one is distribution and disposition. So ADME, all 4 processes are known as drug disposition. Not distribution, but disposition. And as mentioned, M and E, they group those together because M and E collectively is known as drug elimination. So be very careful when you see any of those terms. Absorption. Absorption is just getting the drug into the blood. Some drugs take a long time and you don't get 100% into the blood. Other routes like IV, pretty much 100% and immediate absorption. Distribution. Now that it's in the blood will need to carry it to the site of action. Now the blood does not reach every part of the body. There's some parts of the body that does not have a blood supply. For example, the top layer of skin, inside the eyeballs, inside synovial joint capsules. There is no rich blood supply, so the drug may not reach that site of action. Metabolism. Metabolism will usually occur in the liver. That's our metabolic center. Tons and tons of enzymes that will break down these drug compounds into their breakdown products. Those breakdown products are referred to as metabolites. And then excretion. The main organ of excretion is going to be the kidneys, as the liver changes the drugs, puts it into the blood, and then the kidneys will filter out the blood. Diffusion. Passive diffusion. So things will naturally go from high to low concentration. So just think of any fragrance, perfume or cologne. It's concentrated in the bottle. And as soon as you give a little spray, those molecules of cologne and perfume would diffuse throughout the whole room. It didn't take you any energy at all. You just spray it where you're at, and eventually at the back of the room, all over the room, you'll get some molecules of that scent. Biological membranes, of course, as mentioned earlier, part 1, they're made out of lipids and protein. So it's a phospholipid bilayer. The most important for us is to remember there's a layer of lipids that you must pass through to get inside the cell. So the cell membranes are fat-like because of that phospholipid bilayer. Fat-soluble, so they repel water, so they are hydrophobic. And since that cell membrane is also fatty, they'll penetrate the membrane a lot easier. Whereas water-soluble drug or protein-based drugs are hydrophilic, they light water. So their receptors will most likely be on the outside of the cell. Hydrophilic drugs move through water-filled passages of water. Yeah, so if you have a cell and you have a special transport mechanism, whether it's controlled by proteins, ions, pH, etc., it'll allow for a direct path for certain things to enter. Right? So let's say it's your protein drug that's charged. Active transport. So the opposite of passive transport, here we're going to go from not high to low, but from low to high. So in the reverse analogy, you got that cologne that you sprayed, and it went all over the room, but you found out that you have somebody in the back of the room that's allergic to it. So what do? You gotta run around and put every single molecule back in the bottle. You went from low concentration, now back to high concentration. So definitely that's gonna take a lot of energy. All right, that concludes part 2 of basic pharmaceuticals. Coming up next will be basic pharmaceuticals part 3. So that will bring us to basic biopharmaceuticals part 3. So thanks for joining us. I'll see you next time, or I'll see you in class. Thank you.